Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk Behind the OR.
Good morning. Welcome to Behind the OR, the Peter Surgical Podcast channel. We are here today to speak about minimal invasive coronary artery bypass grafting. Don't forget to listen our first episode on this topic. The objective today is to speak more about technical information. So maybe can you introduce yourself, Dr. Diab?
I'm Mahmoud Diab, Chief of Cardiac Surgery Department, Cardiovascular Center, Rothenburg and the Fulda, Germany.
So welcome to Behind the OR, and let's talk about minimal invasive coronary artery bypass grafting. So during the first episode, we introduced what is a minimal invasive approach, and today the objective is to understand your practices and your procedures. Firstly, can you explain us what is your IMA takedown techniques?
The internal thoracic artery is the most important bypass for this operation. So for this technique, actually, doesn't make a difference whether the mammary be harvested, skeletonized, or pedicled. Because why do we pedicle the mammary? Because we are afraid to have wound infection. Skeletonized mammary, we preserve the vasculature of the sternum better than pedicle. But through this technique, it's not relevant because we do it through many thoracotomy, and we don't have deep sternal wound infection in this technique.
Mm-hmm. So what are the challenges performing the IMA takedown through a smaller incision?
The most challenging is harvesting the right internal mammary through this incision. Okay. We do it through direct vision. Mm-hmm. We have to select patients for the harvesting of the right mammary. We have to select patients with body mass index less than 35. Otherwise, it will be difficult, and the distance from the incision to the right mammary is too long. We are developing a technique to harvest it with the 3D endoscope. Okay. I think this will facilitate it. And the second challenging step is to target the PDA, the PDA branch of the right coronary artery.
Mm-hmm. So, do you prefer to skeletonize the IMA, or do you prefer the pedicle technique?
As I mentioned, for this technique, it's irrelevant. But through stenotomy, I prefer to skeletonize. Okay. However, data regarding skeletonized versus pedicled are mixed. And if we look to the STS data bank, retrospective registry, there is less wound infection in a skeletonized mammary than pedicle. However, data from post-hoc analysis from the COMPASS trial showed that cardiovascular events are more in skeletonized than in pedicle. Mm-hmm. So it is not clear. It's still not clear which technique is better, and I think it comes on how you do it. Surgeons who are performing it regularly skeletonized, so they will have good results. But if you usually do pedicled and then you try to do skeletonized, so you can get worse results.
Okay, understand. And do you have any specific suggestion to other surgeons on getting optimal visualization in the smaller incision?
I think my advice is to start with off-pump surgery
Okay.
So the surgeon who's doing minimal invasive CABG, mixed CABG, should perform some off-pump CABG to get used to the blower, to the stabilizer, to the technique. And then he should start with an easy mid-cap, so only Lima LAD, Lima to LAD. So this is also this is performed in many centers.
Yeah.
The Lima to LAD, mid-cap Lima to LAD is performed in many centers and have good results. So the surgeon can start with this technique and then can develop himself to perform mixed CABG.
Okay. So firstly, where do you do your incision?
This is a very good question. I look at the X-ray of the patient, and I look where is the apex, and I open in this place, intercostal place. As I started this technique, I used to do the incision medially in the mid-axillary line, below the nipple, about 4th or 5th intercostal space. And then I noticed the more laterally I go, the easier will be the operation.
Mm-hmm.
Then I performed the incision more laterally, 1/3 medial to the mid-clavicular line, and 2/3 lateral to the mid-clavicular line. And now I do it even more laterally in the anterior axillary line and almost parallel to the anterior axillary line, so more vertical than horizontal.
Okay.
This is very important, especially in women with large breasts, because you avoid opening in the breast, and it gives a better exposure.
So you always perform mini thoracotomy approach.
Yes.
Okay, interesting. So let's start about IMA takedown. So in terms of tools, your tools are sufficient, or you need to adapt or to make modification?
So we're still developing the instruments we're using. Through this small incision, it's sometimes difficult for the assistant to hold the graft. So we're developing a graft holder.
Okay.
That we insert through the skin. And the 3D camera. I tried the 3D camera in 1 or 2 patients, and the vision is much more better than direct vision. So I think 3D camera will develop this technique. Robotic surgery, of course, but it's not available in Germany. So robotic will improve this technique, definitely. For the stabilizing the anastomosis, I used to start to use stabilizers that go through the main incision, and now I move to use stabilizer that you can introduce between the ribs, one space higher or lower than the main incision, so it doesn't disturb you during the anastomosis. Yeah.
Okay, interesting. So that means that you want to maybe develop more in the future 3D vision, new technologies, tools in your procedures, is it right?
Of course. I'm not alone. We are discussing with surgeons who are performing this technique. How do we develop the instruments? And some instruments companies are helping us in this regard. So we're still working on it.
Mm-hmm. Let's see what will appear in the future.
Yeah.
When you perform a proximal anastomosis in minimal invasive approach, what are the challenges associated to these gestures?
As I started, I did the proximal anastomosis as described by Roel and his group. I used to use the normal partial clamp.
Okay.
Then I moved to flexible partial clamping. And then in the last 5 or 6 years, I perform only proximal anastomosis on the memory. So aorta no touch technique in order to decrease the incidence of a stroke.
Okay.
I don't do any proximal anastomosis to the aorta anymore.
Okay. To preserve the aorta?
To avoid touching or mobilizing plaques in the aorta and causing stroke.
Okay. Interesting. I know that we can perform procedures in off-pump and in on-pump surgery. You mentioned that you perform off-pump procedures, but when do you choose to perform off-pump or on-pump?
This is very important. As I started at the beginning, I performed the 2 or 3 first cases on pump. So I cannulated the femoral artery and vein, went on pump, and did anastomosis. And I advise everyone who wants to start first with cardiopulmonary bypass.
Okay.
I did it beating heart, but with cardiopulmonary bypass, without cardioplegia, without clamping of the aorta. And then I haven't used it anymore, but in every patient with multi-vessel mixed CABG, I insert, before I start the operation, I insert 2 sheaths in the femoral artery, one in the femoral artery, one in the femoral vein, in order to be prepared. If I have to go on pump, it won't take long time to find the artery or the vein. Mm-hmm. So everything is prepared to get immediately on pump if it is needed.
Okay.
Yeah. There are some groups of surgeons who are doing it on pump with cardioplegia, also with good results. I think the technique is also developing. One of the advantage of this technique, of course, that you have the heart is smaller, so you can mobilize it mm-hmm. more inside the thorax through this small incision, and they can target all vessels.
And what is the proportion of off-pump and on-pump for you?
For me, through sternotomy, I perform most cases more than 95% through off-pump.
Off-pump, okay.
And in some selected patients, like recent infarct, I do it on beating heart with cardiopulmonary bypass, okay. but without cardioplegia. Through many thoracotomy, I do all the cases off pump. Just as I mentioned before, at the beginning, I started with 2 or 3 cases on pump, and then I performed all cases off pump.
Mm-hmm. Okay. Thank you very much for this episode, Dr. Diab, and see you for the third one and the last one of this series of minimal invasive coronary artery bypass grafting.
You're welcome. See you later.